Traumatic Injury in the Elderly, Examining the Complexities of Geriatric Trauma by Savannah Baltezegar, Katie Britt, Leslie Fox, Christine Gold, Andrew Price, and Jessica Small. As the average age of the American population trends upward, so does the prevalence of traumatic injury in these older adults. Without focusing on the rate of traumatic injury in the elderly population, the healthcare system is failing to meet the needs of a significant portion of its dependents. To ensure better outcomes for the older adult with traumatic injury, the healthcare system must establish better practices, including rapid but in-depth assessment, close monitoring, and injury prevention strategies. Many organizations around the world have different classifications for the older adult. While these organizations are well-researched and regarded, large hospitals in the United States typically follow guidelines established by the Centers for Disease Control. For the purpose of this presentation, we will be using the CDC established criteria defining the older adult as a person aged 65 or older. As we make advancements in healthcare, we are creating a new opportunity for aging. People have greater access to medicine and other health-promoting resources, and are in turn living longer than ever before. This increased life expectancy means that the population's average age is increasing at a rate like never before. While the average age of the world's population is increasing across the board, the U.S. is moving at a significant rate. The United States Census Bureau is projecting that the population of adults over the age of 65 will outnumber those aged 18 or under by the year 2034. Presently, there are two accepted classifications of trauma, these being physical trauma and mental trauma. For the purposes of our research, we will be gearing our focus toward the complexities of physical trauma in the geriatric population. Physical trauma is defined as tissue injury that occurs more or less suddenly due to violence or accident and is accountable for initiating hormonal, immunologic, and metabolic responses that are responsible for restoring homeostasis. This trauma is currently the fifth leading cause of death in the elderly population. While most adults are not at high risk for low-energy related traumatic injury, the geriatric population both attains and manifests trauma far differently. Falls from standing, household accidents, and other low-energy incidents may not impact the general population, but they can be devastating for the older adult. In the United States, we are expected to see a 20% rise in the number of older adults by the year 2050. With this increase also comes an increase in trauma admissions, estimated to reach a 39%. Older adults are at a higher risk of mortality due to their physiological differences and increased comorbidities. A higher mortality rate may also be attributed to older adults being under-triaged when presenting to the hospital. The two most prevalent causes of unintentional injury in the older adult are motor vehicle accidents and low-energy falls such as those from standing heights. According to the CDC, every second an older adult falls, with approximately 36 million occurring every year. As a result of these falls, we see fractures with a particular emphasis on hip injuries, traumatic brain injuries, and hematomas. Also a result of these falls are an estimated 32,000 deaths a year. In the past decade, this rate of deaths from falls in the older adult has risen nearly 30%. According to the CDC, the incidence of traumatic brain injuries has increased by nearly 30% in the last decade. Among the geriatric population, these instances are most caused by falls or motor vehicle collisions. Among traumatic brain injuries, the geriatric population has the highest rate of hospitalizations and deaths as a result. They also accrue the lengthiest recovery times related to physiological deficits and complications. Traumatic brain injuries in the elderly often manifest in memory and other cognitive disturbances, sensation changes, motor function deficits, and emotional lability and depressive states. In a population already so at risk for decline in these areas, it is imperative that prevention and prompt intervention takes place to reduce further negative impacts. The geriatric population is often under-triaged when they arrive in the emergency room. They may not have the typical indicators that the general population would, that they are experiencing complications of their injury, and require very specific and detailed assessment to receive better outcomes. The personnel triaging these adults must take into account factors such as alterations in vital signs, altered physiologic responses as a result of medication use, as well as potential medication-induced complications, and comorbidities that may either cause a different presentation after injury or a sudden decompensation. The geriatric population lives at a different physiological baseline than the younger adult. They have a decreased functional reserve, meaning that they will decompensate much more suddenly than others. They have an increased comorbidity level, which can impact their responses to trauma depending on the illness itself. They take medications that increase their risk for negative outcomes, such as anticoagulants, increasing their risk for fatal hemorrhage, or medications that may have a negative interaction with medications administered during trauma care. To provide specialized and effective care for these patients, we must consider these differences when implementing interventions and be on high alert for subtle changes that may indicate an impending decompensation. Utilizing a multidisciplinary team approach is a great way to promote positive outcomes following geriatric trauma. Geriatricians, who specialize in treating older adults with multiple health problems, are essential resources for consultation, as they are adept at the subtleties of geriatric physiology and can help bridge the gap. Utilizing ortho-geriatrics and physical therapists who specialize in the older population makes room for prompt functional return and recovery, reducing the rate of mortality and other consequences of immobility. Relying on a team approach creates space for new approaches and ideas, as well as covers all the bases when it comes to harm reduction and recovery. The Geriatric Surgery Verification is an example of one program committed to surgical care improvement in the older adult population. While it is not specifically dedicated to trauma care, it still caters to the health issues of this vulnerable population and addresses issues that may either be causes of geriatric trauma, such as opioids, polypharmacy, and pain, as well as aspects of traumatic event outcomes, such as care goals and interdisciplinary care management. This is just one of many programs that can improve the quality of care and outcomes for the older population. Programs like these are thought to improve care by setting evidence-based standards that can be utilized across the board, whether it be in a community or university hospital. Newly implemented at WakeMed Cary Hospital, the Tiger Alert System, or Trauma and Geriatrics, aims to reduce mortality and traumatic injury in the elderly population. This system prioritizes elderly individuals taking blood thinners who have fallen and hit their heads in any capacity, no matter how minor. Because the use of blood thinners dramatically increases the risk of bleeding, it is imperative that any head bleed is immediately identified. These individuals receive immediate evaluation by an emergency provider and are prioritized for CT scan with a goal of door-to imaging in under 30 minutes. Life-threatening injuries such as head bleeds are now being immediately identified, resulting in prompt intervention. Older adults with traumatic injuries typically acquire longer hospital stays due to the complexities of their injury. Because of this, they are at an increased risk for complications such as delirium and infection. Delirium in these patients may be related to pain, excessive stimulation by members of the care team and medical devices, and sleep disturbances caused by the same. Prevention of such includes frequent cognitive assessments to alert for impending delirium, frequent reorientation, pain control, and, if possible, changes in the environment. This may include opening and closing windows during wake and sleep time, and visits to outside areas such as courtyards or other seating areas. Preventing the development of infection is essential in all hospitalized patients, but especially in the elderly, as they have an increased transmission risk factors than the general population. Care team members should practice frequent repositioning to prevent skin breakdown, engage in regular hygiene interventions such as bathing, linen changes, and incontinence care, and follow all hospital-provided, evidence-based practice bundles to prevent and treat infection. While mortality from low-energy falls is decreasing due to greater time and focus spent on prevention and treatment, morbidity remains substantial. After a fall, there is a turning functional decline as the rate of immobility increases. When approaching discharge, utilizing geriatricians, physical and occupational therapists, and home aides is essential to maintain functional ability and independence. It is the role of the nurse to ensure that the geriatric client is connected with all necessary resources for discharge and understands the need to maintain activity at home. Following a traumatic injury, the older adult is at an increased risk for falls, whether their original injury was fall-related or not. The impact of a traumatic injury on the aging body makes mobility a greater struggle. With each traumatic injury, the mortality risk further increases, as does the risk of repetition. Prior to discharge from the hospital, conduction of a thorough home assessment is essential for safety and to prevent reoccurrence. This assessment includes removal of throw rugs, objects from walkways, installation of assistive devices such as grab bars, raised toilet seats, and shower converters. Prior to discharging the older adult after a traumatic injury, it is essential to perform a thorough home safety assessment. Some important things to look for are any loose or uneven steps. Ensure that all walkways are adequately lit. Have handrails and grab bars installed for safe transitioning. Place non-slip mats in the shower or tub, as these are high-risk areas for the older adult. Ensure that all pathways are clear and free of clutter or throw rugs. And make sure that all essential items are in easy-to-reach places to eliminate the need for climbing, step stools, or reaching. These home safety assessments help prevent the recurrence of falls in the home by ensuring a safe home environment to return to. Research shows that university hospitals have better outcomes in regard to trauma in the older adult and mortality rates. This is thought to be because university hospitals have improved research, resources, and innovation that is often found lacking in community hospitals. Unfortunately, most older adults present to community hospitals rather than university systems. Not only is it important to recognize risk factors and injury patterns that the older adult population experiences to promote quality improvement, but care should be nationally standardized across hospital systems so that those vulnerable populations in rural areas don't slip through the cracks. Traumatic injury can be better prevented if we focus on identifying the source. Many geriatric traumatic events, such as falls, are a direct result of the consequences of aging. For example, older adults are at a higher risk of falls resulting in injury related to bone density issues from osteoporosis, or disorientation and weakness from increased infections or polypharmacy. If we are able to identify these sources, give proper education, and maintain health status, we can reduce these traumatic instances. With an ever-growing proportion of our society belonging to the older adult, it is highly imperative that we make the necessary adjustments to accommodate their needs. It would be a disservice to continue operating within a system that does not protect and serve as vulnerable dependents. If we, as a healthcare system, are able to analyze, identify areas where improvement is necessary and possible, and implement substantial changes, we can improve the outcomes of geriatric traumas and give this vulnerable population the quality of care that they deserve. It is our responsibility to bridge the gap between rural community hospitals and major institutions to provide a clear, efficient, and effective standard of care that meets the needs of all its people, especially when the older adult is set to make up a major portion of the population in the years to come.